Next case is from SCB Medical College, Cuttack.
Yeah, they are there. So they are there.
You start sharing your screen, and I request the examiners to have something to grab. Virtually, of course, I cannot offer anything. Extremely sorry for that. Okay. Next case is from SCB Medical College, Cuttack.
Yeah, they are there. So they are there.
You start sharing your screen, and I request the examiners to have something to grab. Virtually, of course, I cannot offer anything. Extremely sorry for that. Okay.
Myself, Helva Bharati from SCB Medical College, sir. With my colleagues, to my right, Dr. Saurav is there, and to my left, Dr. Swapnil is there. Sir.
You start presenting.
Going to our case, our patient, 17-year-old Hindu female from lower socioeconomic status, resident of Jajpur, Odisha, student of 12th standard, was admitted with chief complaints of bilateral upper limb pain on activities since 4 months, breathlessness since 15 days, and fever for 15 days. 15 days back. History of presenting illness. Patient was relatively all right 4 months back when she developed bilateral upper limb pain on lifting heavy objects with either hands, washing clothes, cleaning utensils, which was relieved after stopping the activity for 5 to 10 minutes. It worsens since last 15 days, so that she has pain on minimal activity like combing her hair and having food. It was not associated with any heaviness in chest. The pain was dull, aching in nature, diffuse, non-radiating, and mostly involving both forearms. And there is no history of skin changes, cold skin over both upper limbs, no history of increase in pain on exposure to cold, no history of intermittent limb weakness. She has history of 2 episodes suggestive of PND, for which admitted to her hospital. No history of orthopnea. After treatment, her symptoms improved so that she could do her day mentioned above since last 7 days without any breathlessness suggestive of NIOSH. No history of cough with expectoration, no history of increase in breathlessness on exposure to cold. She developed fever 15 days back, which was low grade, intermittent, associated with not associated with sore throat, cough. There was no history of palpitation, chest pain. There is no history of loss of consciousness, transient ischemic attack, headache, double vision. No history of syncope, vertigo, no history of lower limb claudication, no history of prolonged fever or joint pain, no history of pedal edema, abdominal distension or nausea. Coming to the past history, there was history of intermittent low-grade fever 1 year back associated with loss of appetite, loss of weight, malaise. She was treated at a local hospital for the above complaints and fever subsided in 1 month. No history of tuberculosis, hypertension, jaundice, or diabetes mellitus. No history of blood transfusion in the past. No history of sore throat, fleeting type of joint pain, and taking injectable medicine every 3 weeks in the past. Drug history, there is no significant drug history in the past. Family history, there is no significant family history of similar illness or hypertension, tuberculosis, ischemic heart disease, diabetes mellitus, or peripheral artery disease. She is born of non-consanguineous marriage. Personal history, she consumes a mixed diet, bowel and bladder habits are regular, sleep is adequate, loss of appetite present since 15 days. There is no addiction. Menstrual history, menarche attained at the age of 12 years. Menstruation is regular, 3 to 4 days, average flow, no history of menorrhagia. Last menstrual period was 5th August 2021. Coming to the summary of history, 17-year-old girl without any previous comorbidity presented with progressive bilateral upper limb claudication since 4 months, sudden onset breathlessness on exertion, NIOSH class 3 with history of PND since 15 days, which improved to NIOSH class 2 after medication, and low-grade intermittent fever 15 days back, which was lasted 5 days with significant past history of constitutional symptoms of fever, loss of appetite, loss of weight, and malaise 1 year back. With this history, sir, we give a differential diagnosis of non-specific aortoarthritis, coarctation of aorta of preductal type with aberrant right subclavian artery, primary hypercholesterolemia could be a possibility, but she's not telling any presence of joint swelling, or there is no history of similar illness in the family.
So what gives you keep non-specific aortitis on the top?
So because she's having non constitutional symptoms like fevers, or loss of weight, loss of appetite with upper limb claudication, sir.
So,
And she's a young female.
yeah, fever in a young female. That is one of the major complaints.
Yes, sir.
So, what are the possible causes of fever and cardiovascular disease? Because
So
I think you should add some more stuff in the differential diagnosis.
Yes.
We'll try to come to that.
Yes, sir. One is arteritis, or could infective endocarditis, sarcoidosis, left atrial myxomas, acute rheumatic fever.
Good.
Did you hesitate to keep that aortitis on the top because of bilateral involvement? Symmetrical, bilateral,
Associated
aortitis, symmetrical, bilateral, both are a possibility or there is?
Sorry, sir, your voice is breaking.
On
sir.
non-specific aortitis, bilateral involvement, both limbs, upper limbs, is it a possibility or is it rare?
Yeah,
Non-specific arteritis commonly aorta and its branches.
yeah, Wifley, I think, I mean, you placed aorta arteritis as your first diagnosis. We fully agree with the history and this thing. So coactation, when coactation, and another
Yes.
important thing we wanted to know is, yes, this patient had initially started with upper limb claudication, then developed breathlessness, PND and all. So you also put coactation of aorta as a
Yes.
differential diagnosis. You are thinking of preductal, huh? Hello.
Yes, sir, preductal.
So what is the natural history of preductal coactation of aorta? Because this girl is about 17 years. Okay. So what will be the natural course of this preductal coactation?
It's very when associated with the turners, it is 5% percentage patients present. Other than without the turners, it is less than 2%. So
No, when do you get claudication in both the upper limbs in coactation? That is the thing we are asking.
it is preductal with right subclavian aberrant right subclavian arteries. Sir.
Okay.
Bilateral upper limb claudication will be there.
Will you
Yes.
consider infective endocarditis as a potential etiology in this case?
Yes, the infective non-specific there's a but she's having claudication most commonly in the forearms. If it is endocarditis, there will be hand pains and ischemic fever will be prolonged fever.
Throat and see which came
Her
first?
fever
Can you come again?
Sir.
Which came first? Fever came first or joint claudication pain came first?
for her, so claudication came first. Sir.
Oh, it's okay.
Is there any family history of premature coronary artery disease?
No, sir, no, sir.
Suppose if somebody has got this, what will be the presentation of Kawasaki?
So Kawasaki usually present less than 5 years of age. So
Atypical. They can also present with fever.
yes, sir. Non-specific symptoms like fever, joint pains, skin changes.
Can they
And
develop
coronary,
this?
they commonly involve the coronary arteries. So they present with angina.
Even axillary arteries, they can have the axillary artery aneurysm, and they can have thrombosis. Of course,
Yes,
I fully agree. It's more common in younger children.
Yes, sir.
And what is the reason for this PND in this case, if it is non-specific aorta arteritis?
So could be associated regurgitation like aortic regurgitation, LVF because of myocarditis, coronary artery disease, so dilated cardiomyopathy, hypertensive heart failure.
Suppose if the same presentation were to be acute, what you would have thought? A patient has got some pain in the ischemic pain in the arm and sudden onset of breathlessness. If the whole history would have been acute.
So acute aortic regurgitation, sir.
Yeah.
Acute myocarditis because of
No, myocarditis don't bring, because I'm talking about severe ischemia of the upper limbs, either one or two, with sudden onset of breathlessness.
Acute aortic regurgitation is a possibility, sir. And infective
dissection, okay? So,
aortic dissection is.
yeah, aortic dissection can cause pain if it extends into subclavians. They can have pain, and of course, the whole presentation will be acute. They can have acute AR.
Yes, sir.
Okay.
Myocarditis and aortitis, which is the age group that are affected most?
Young patient, second decade, so second or third decade. Coming to the general examination, patient is conscious, oriented with time, place, and person. Height is 148 centimeter, weight is 37 kg, with BMI of 16.9 kg per meter square. Temperature is 97.3 Fahrenheit. Pulse 84 per minute, regular, low volume, no special character, normal vessel wall. Coming to the peripheral pulses, left internal carotid artery is feeble, internal carotid artery is well-fed, left brachial, radial, ulnar absent, radial or feeble, ulnar is absent, and other limb pulses were well-fed. Lateral subclavian artery and left carotid artery systolic buoy is present. No tenderness on palpation of both carotid arteries. 16 per minute, thoracoabdominal type. Blood pressure, right upper limb, it is 18, left upper limb not recordable. Both lower limb is 130 millimeter of mercury systolic. Saturation is in all four limbs, it is 98%. JVP, it is not raised with normal. Pallor is present. There is no icterus, no peripheral signs of hypercholesterolemia or aortic regurgitation. Back and spine normal, visible pulsations. Fundus examination, there is grade 1 hypertensive retinopathy. Apical impulse could not be visualized. There is no suprasternal, epigastric, parasternal, or back pulsations. No scar or dilated veins. Palpation, inspective findings are confirmed. Apex beat is palpable in left fifth intercostal space, midclavicular line, localized, heaving suggestive of LV type of apex. There is no thrill or passional heave, no palpable heart sound. Percussion, upper border of liver dullness is present in right fifth intercostal space in midclavicular line. Gastric tympani is on left side. Left heart border correspond to apex. Right heart border is substernal, and left second intercostal space is resonant. Coming to auscultation, S1 is soft. S2 is normally split with normal A2 and P2 component. No S3 and S4. Bilateral infraclavicular systolic buoy present. Left internal carotid artery systolic buoy is present, and there is no other added sounds. Coming to the respiratory system, bilateral vesicular breath sounds are present, no added sound. J system is normal, and CN is also normal. Coming to the summary of history and examination, 17-year-old girl.
1 second, doctor, no murmur, huh?
There is no murmur.
No precardial murmur, right?
No, sir.
Only heaving apical impulse.
Yes, sir.
Okay.
Did she say heaving apex? Okay, I thought she said the LV type of apex. Was it a heaving apex also?
Yes, sir.
Yes, sir.
Yes.
Oh, okay, thanks.
With the findings of absent upper limb pulsations, feeble pulses in right upper limb and left carotid artery, with normal bilateral lower limb pulsations, pallor, buoy over bilateral subclavian artery and left carotid artery, soft S1 and heaving LV apex on examination.
Soft S1.
With these findings and history, we professional diagnosis is chronic inflammatory arthritis affecting large vessel in the form of left carotid, left subclavian and left subclavian and right subclavian arteries, probably due to non-specific aorta arthritis. mild pulmonary venous hypertension, no pulmonary artery hypertension, LV systolic dysfunction, could be due to acute myocarditis, normal sinus rhythm, not in CHF, no infective endocarditis, recent acute disease activity, currently in NaOH class 2 with anemia.
Any renal bruit?
No, sir, it's not filled.
Look for, right?
Yes, sir, yes.
How do you explain soft S1 symptom pulse is 84? This examination was done after stabilization of the patient of the
Yes,
movement.
yes, sir, yes, sir.
How do you decide S1 was
This
soft?
one could be due to LV dysfunction, sir.
How do you decide S1 is soft?
So when compared to S2, sir, it is
Compared
soft.
to S2, is it? Which S2?
Pulmonary components.
No.
You think the patient has central aortic hypertension and that could have caused the heaving apex and that could have been the cause of LV systolic dysfunction?
Yes, sir.
Is it possible?
It's a could be possibility.
But you said A2 was normal.
It is normal.
Yeah, then what will happen to A2 with central aortic hypertension?
Loud A2 will be there. Here could be due to the LV dysfunction.
So was there any S3?
No, sir, there is no S3 or S4.
There is no cardiomegaly but a heaving apex.
Yes, sir.
No cardiomegaly, heaving apex, and no S3.
Yes.
And you say LV systolic dysfunction. Why is there heaving apex in LV systolic dysfunction?
So because heart moved towards the chest wall, it is close to the chest wall, so it's like giving type of attacks.
Why is not
It is
moving
also
towards
thin built, sir.
What is the normal apex due to?
LV, sir.
Yeah, during why is it happening? How will you define apical impulse?
It is the lowermost and outermost definite cardiac impulse.
Due to which phase of systole you get it? My point is, I am trying to find out why the apical impulse is heaving in LV systolic.
No, Shailudu mildly positive.
Why is the it is heaving? The heaving
ನೀವೆಲ್ಲ ಮಾಸ್ಕ್ ತಿರ್ಗಾ ಬಿಗಿಯಾಗಿ ಹಾಕೋಬೇಕು ಎಲ್ಲರೂ.
aortic stenosis, or why is it heaving in LV systolic?
ಸೋಮವಾರ ತಿರ್ಗಾ ರಿಪೀಟ್ ಮಾಡಿ ನೋಡೋಣ.
Or what is the evidence? Why do you say the patient has LV systolic dysfunction? What are the evidences for you to identify LV systolic dysfunction?
Soft S1 is there, and she presented with acute onset shortness of breath, PND, sir.
That doesn't mean LV systolic dysfunction, right?
Yes.
Only soft S1 is there. With that, you say LV systolic dysfunction.
And heaving apex also, one of the causes.
Why do you see heaving apex in LV systolic dysfunction? Why is the LV apex heaving in LV systolic dysfunction?
Heaving relates to the amplitude or the duration?
The duration, sir.
Yes, so that's what.
Here, because of LV dysfunction, prolonged isovolemic contraction.
Which phase or why is the apical impulse due to? Why is
in isovolemic contraction phase.
Right? Why is it coming out? In systole, it becomes smaller. But then why is it coming out and touching your hand?
You have to go back to your physiology days now. Because it is how are the myocardial fibers are arranged in the LV spirally.
Yes.
So when it contracts, okay?
Yes.
So there's a counterclockwise rotation of the apex, and that's how it touches the chest wall, okay?
And this happens during the isovolumetry contraction.
Yes.
Right? And this isovolumetry contraction phase is prolonged in LV systolic dysfunction. Yes. And that is the reason you're having it as a heave.
Yes.
But the only thing is you didn't hear S3 and S4, okay? There is a LV systolic dysfunction.
Yes,
LV compliance, what happens to compliance in LV systolic dysfunction? Or maybe already that. Diastolic dysfunction, what happens to LV complaints? There will be both. When patient develops LV systolic dysfunction, there will be some diastolic also.
Yes. So we examined the patient after decongestive therapy, sir.
Okay.
So
Otherwise,
LVS was not filled. So third.
okay. So now your explanation for heaving apical impulse is only myocarditis or with some sort of a, because sometimes even in myocarditis, when over a period of time there can be hypertrophy also. Some people develop a bit of hypertrophy.
Yes.
Or as Professor Paul was telling, whether there could be, because you are not able to measure the blood pressure because of subclavian partial occlusion. It could be central LV pressure may be still high. There can be a central hypertension.
Lower limb pressure is 130 millimeter of mercury, sir. Even with LV dysfunction, our BP is 130 by 130 millimeter of mercury, sir.
Any abdominal bruit? No.
No, sir. It's not filled.
Because they can have some abdominal coarctation also.
Yes.
Okay. So it fulfills your American Rheumatology Association criteria for
Sir,
arthritis?
sir, ACR criteria, her age is 17 years, so less than 40 years. She's having claudication, sir, and there is decreased brachial pulses, and there is a discrepancy in the both upper limb blood pressure, sir, and bruit is present, sir.
Yes.
Subclavian bruit is present, sir. So almost she is meeting 5 criteria out of 6, sir.
Vision is normal.
Yes.
Vision is fundus, there is hypertensive changes, but she's not complaining of any vision abnormalities.
Does it require any other investigation to meet to this criteria?
It's angiographic.
CT aortogram, sir.
Okay.
So you can go for the ECG then.
Yeah, ECG, X-ray, and other images. Any investigations done?
What is middle aortic syndrome before you go there? What is middle aortic? Which comes to the closest differential diagnosis for coarctation of aorta?
Yes, sir.
You here entertain
arthritis is a
subclavian. What is middle aortic syndrome?
So, non-specific aorta arthritis involving the aorta and its branches.
Aorta and its branches?
Descending thoracic aorta, abdomen.
Specifically descending thoracic.
Descending aorta.
Where who described it?
And from where? Very interesting.
Okay, describe the ECG, please.
ECG, sir, it is standardized 12-lead surface ECG, normal sinus rhythm with QRS rate of 94 per minute, 120 milliseconds. Axis is plus 60 degree. There is no evidence of chamber enlargements.
Are you surprised or what?
No, so it's acute myocarditis, so we are not expecting any chamber enlargements.
AVL is biphasic.
Your clinical told us heaving apex and all, right?
Yes, sir.
So
But there is no LVH, sir. And also in case of suspecting myocarditis, but there is no significant any SCB changes.
But if the SPT changes, is there any suggestion of early?
There is early repolarization abnormality in the inferolateral lead, sir.
Is there any prognostic importance?
Yes, sir.
Yes, go ahead.
It is more prone if early repolarization is a malignant type of early repolarization syndrome has higher chances of sudden cardiac arrest and ventricular arrhythmias.
Is it there?
No, sir.
Very well.
Coming to the chest X-ray, it is chest X-ray PA view with adequate exposure with CT ratio of 0.48. Seems to be normal. No, there's no evidence of PVH, PAH.
Is the haziness in the field lower? Middle and lower.
Middle
These
and
are in middle
lower
and the low,
zone,
low,
lower
in the
zone.
middle lobe on the right side and the right side also, sir, there is some dizziness.
Do you see some pulmonary veins in the left first anterior intercostal space?
Yes, sir. A few on the left side.
So
Yes,
there,
sir. This,
what is the normal size of the pulmonary vein in the left first anterior intercostal space?
sir, it should be ideally less than pulmonary artery size, sir.
No, it's not about the pulmonary artery
And
size.
it should be the.
There are some, and normally, do you see pulmonary veins on the right lower zone? How do you identify pulmonary artery versus pulmonary vein? I'm not talking about the central
Going away from the hyla, and the pulmonary veins are towards the hyla. And
No, is pulmonary vein lateral, upper lobe pulmonary veins are lateral to the artery or medial to the artery? Must have done ASDs.
so these are the medial to the artery, sir.
No, vein goes laterally, okay?
Sir, artery is in the medial and the vein is in
Yeah, artery is medial, vein goes laterally. But in the rest of the body?
It is another opposite, sir.
Yeah. What is normotensive coarctation?
There is a coarctation, but there is without any evidence of hypertension because of there is baroreceptor because of there is no baroreceptor sensitivity, increase in the sensitivity or higher in the
No, if
receiving of
if
the
both the subclavian are arising below the coarctation, then there will be normotensive.
Yes, sir. Yes, sir. Because all the four limbs will have the equal pressure.
Is there any LV contour?
Yes, sir.
Because why I am asking that question? If there is an LVH or if the outer border of the lower border of the LV is convexity is there, that again suggests this patient may be having hypertension.
When she has grade 1 hypertensive changes in the eye.
Yes, sir. Yes, sir.
Coming to the blood investigation, so hemoglobin, it is 8.2 gram per deciliter. WBC count is raised. Platelet is 1.6 lakh. ESR is raised 120 millimeter at 1 hour. CRP is raised. Urea creatinine normal. Tropi is raised 9 times raised. Lipid profile is within normal limits. NT-proBNP is raised. So ANA is negative. Coming to the echo findings, so it is parasternal long axis view with LA of 22 millimeter, aorta 21 millimeter, and LVOT and normal diameters. Coming to the LV contraction, 4 chamber, 2 chamber, 3 chamber view, and short axis, parasternal short axis view. There is global hyperkinesia of left ventricle. The M mode, LV internal diameter is 43 millimeter. Systolic dimension is 36 millimeter. EF is 32%. Fracture shortening is 15%. And EPSS is 13 millimeters. This color Doppler across aortic valve, there is no aortic regurgitation and gradient test of 1.3 and 6. Color Doppler at the pulmonary valve, there is no pulmonary regurgitation. Color Doppler at mitral valve, across mitral valve, there is trivial mitral regurgitation. And across tricuspid valve, there is no tricuspid regurgitation.
Did you try to interrogate that mitral regurgitation?
Yes.
Yes, sir. Yes, sir. We have seen, sir, in the parasternal long axis, apical 4 chamber, 2 chamber, and apical 3 chamber also. But it is only trivial, sir. So, and it was coming. The area was around only 1 centimeter square, sir.
What will you be interested in learning from the mitral regurgitation in this patient?
If it could be because
or something else.
it could be
Aorta arteritis also involvement of mitral valves. Occurs in 11.
in around 7%. In around 7% of the cases of the mitral regurgitation, and if because of LV systolic dysfunction, long-standing, it could be because of the mitral annulus dilatation. It could be there. Mitral regurgitation could be there.
My question is, I'm not asking you why MR is there. Now that MR is there, can you get any information from the MR?
Yes, sir.
LV pressure. LV pressure.
LV pressure.
Right.
Yes.
Yes, sir. LV pressure is on the higher side.
Usually when we are looking at a central aortic hypertension, when
Yes.
seeing that in the upper limbs are, it is the best way to identify the central aortic hypertension.
Yes,
And
sir.
it is appropriately.
Yes.
By MR velocity jet, you can determine the systolic blood pressure. Okay.
Yes, sir.
Yes.
That is not there.
Yes.
Anyway, need
It's pulse Doppler across mitral valve. So E by A ratio is 1.2, and lateral E prime is 9 centimeter per second, and septal E prime is 10, and it is S dash is 7 meter per second.
So it is suggestive
First of
elevation.
LV dysfunction, sir. There is no evidence of diastolic dysfunction. Coming to global longitudinal strain, there is it is reduced, that is minus 11.2%, sir. Mostly involving the anterior anterolateral one and anteroseptal ones. By Simpson's methods, our EF comes around 35% in 4 chamber. In 2 chamber, it is around 41%. Sir. It is a suprasternal long axis view. There is a color Doppler across the aorta. There is no gradient across the aorta. So there is no evidence of coarctation. And in this, you can see, sir, there is no flow across left subclavian and left common carotid. Sir. Coming to CT angiogram, there is severe stenosis of right subclavian artery, mild narrowing of brachiocephalic trunk, and there is severe stenosis of left subclavian and left common carotid artery at their origins. And there is no right venal artery is not visible due to severe stenosis at right venal artery at its origin. Coming to the coronary CT angio, coronaries were normal. Sir. Coming to our final diagnosis, it's a case of chronic inflammatory arthritis affecting large vessel in the form of left carotid, left subclavian, and right subclavian arteries, right renal artery, due to non-specific aorta arthritis with mild PVH, no evidence of pulmonary artery hypertension, LV systolic dysfunction, probably acute myocarditis, in normal sinus rhythm, not in CHF, no evidence of infective endocarditis with recent acute disease activity, currently in NIH class 2 with anemia.
how do you manage? How do you treat?
Dr. Manjunath, please quickly
Okay.
sum up.
Give the outline.
Glucocorticoids, sir. Prednisolone 1 milligram per kg we have started, sir. And she is responded to the treatment also. Her symptoms have come down and her ESR also reduced and CRP also reduced, sir.
I think in the chart box, one of the question is any role of valve implantation in IVC, SVC for RVMF. Anyway, that is an upcoming thing. Then they have to put, to prevent severe tricuspid regurgitation nowadays, that is one of the modality that is available. They have to put one valve in IVC, other valve in SVC.